arterial pressure, and when we saw it before, I think it was at the beginning of the blood vessel section, and we saw a graph that had the tracing of that aortic pressure, right? Aortic pressure, and that was from the Wigger's diagram. And we did notice that kind of at the top, in your average, normal, healthy, young person, that was 120, right, millimeters of mercury, and at the bottom it was 80. And remember, those were our sort of average, normal values. And then there was like a dotted line that was our mean arterial pressure. And we had made a little bit of a big deal saying it's not an average, it's not the midpoint, it's this mathematical mean, which we could calculate using a complicated mathematical equation, but we're not going to do the complicated math. We're going to do, I'm not going to say it's easy math either, but we're going to use this mathematical equation that is a more practical way of calculating what is this mean arterial pressure, this number somewhere in between systolic and diastolic pressures, that is really the driving force for pushing fluid into the tissues, right? Our overall driving force. And this mathematical equation for calculating that is using cardiac output, which we know, right? We know all about cardiac output by now. There's so much stuff, right, about cardiac output. And how do we, what was our mathematical equation for cardiac output? What times what? Good. Heart rate times stroke volume, right? And we know all about heart rate and how we influence that, right? And we know all about stroke volume and how can we influence that, right? That's been our topic for like a week now. Good? So we know how we can get cardiac output. So we can take that, plug it into this equation, and we'll multiply cardiac output by a new item, which is total peripheral resistance, and we abbreviate that with all capitals TPR. Okay? So this total peripheral resistance, that's the new thing that we have to talk about today. Figure out what that is. And then from there, we can figure out what is this mean arterial pressure. Good? All right. So here's another mathematical equation that we're definitely going to use. We definitely want to know this one as well. Good? All right. So, oops. Oh, brother. So here's our book liking this little setup, right, to demonstrate kind of the mechanics of how things are going to go in the body. So we're going to add at the top of this little experimental setup a pump that's going to represent the heart. And then in the middle, those big reservoirs, those are going to represent arteries, like basically aorta and the big branches of the aorta. And then we've got our little tubes sort of draining those arteries, and those have always represented arterioles, so we're going to keep that, right? And then we've got our test tubes at the bottom, and those were always representing individual organs, and we're going to keep that. So we remember from our discussions before that arterioles we can adjust, right, in the body. And here they show us changing the diameters, right, from like one situation to the next, changing the diameters of maybe some of these arterioles. You don't have to change all of them, right? You can just change one, or you can change half of them, or you can change all of them, or you can change 3 of them, right? You can change whatever you want, and we know how to change them, right? Arterioles. How are we going to change them again? What are some ways? We had a whole flow chart of ways, right? We had like intrinsic ways and extrinsic ways, right? So what was, just to do the obvious one, what was like an extrinsic way to control diameter of arterioles? So we're either going to vasodilate or vasoconstrict. Extrinsic. Huh? Hormones. Hormones is a good one, right? What was our hormone that we've talked about so far? Epinephrine. Yeah, the other ones we're gonna. Well, yeah, we had angiotensin too. Exactly, vasopressin. But we're gonna save the details for renal on those. We know they're there, right? But epinephrine was our big example. And then what's our other big example besides hormones for extrinsic control? Norepinephrine, and that's coming from sympathetic neurons, right? All right, so that's good. And then we had all of our intrinsic controls, right? So that's all the stuff you guys are going to study for Tuesday. Good? Tuesday's exam, that kind of stuff. All right. So, looks like we've got our starting situation over here. We've got the heart pumping, blood through arteries, and here we've got 5 arterioles, and they all look like they're the same diameter. They're kind of vasoconstricted, but they're not shut off completely, and they're all the same. Good? So we've got those, and okay, when they're at that diameter, then they each allow this much blood through to their respective organs. And it looks like each organ gets the same amount of blood. Good? All right, so we're going to use this as our starting point. And then when we go from here to here, looks like we've taken this arteriole number 1 going to organ number 1, right? And we have increased the diameter, so we've opened it up, right? It looks like it's wide open. So when that happens, we're able to, we know this, right? Get more blood to flow to organ number 1, right? Okay, if at this particular moment nothing else changes, like we don't change anything here and nothing changes here, then, I mean, something's got to change, right? If you change this flow over here. And it looks like what's changing, if this stays constant, right? So this is the heart pumping, so if the heart rate, right, stays constant, and also that stroke volume stays constant, so cardiac output stays constant. So if this, see cardiac output, 1 liter per minute, 1 liter per minute, if that stays constant, the thing that has to change, right, along with this is going to be this. See how now, oops, we've got less blood in this reservoir, which is representing the big arteries, right? Because, oops, we just drained a whole bunch over here. Make sense? So we've got this sort of transitional situation where just because we allowed more blood to go to this one organ, whatever it is, right? Oh, we kind of dropped that pressure differential in the arteries, right, in the big arteries, by reducing the volume in the arteries, right? So the body's not going to want to stay in that situation for very long, right, or kind of at all, right, because, I don't know, having less blood, right, sort of flowing around in the big arteries could be not good, right? We could compromise some other organs, could be not good. So the body's going to kick in and try to fix such a thing, right? Make adjustments. So we can, I don't know, we're going to start making some adjustments. I'm going to take this, right, and go to the next slide, because I think the next slide shows us a little bit more so that we can see a bigger picture. Oops. Right, look at this slide. Look at this slide. So, same setup, right? And here's our starting point. From here, I mean, they made the diameters a little bit different compared to the first example. But here, this is our starting point. Everything's like the same. That's fine. And they have, what have they done? They increased the diameter here, so we've got a lot more fluid coming to this organ. And this is kind of showing us the result, right? Like things that you could do if you want to. What you really, really want to do is keep this the same, right? So to correct that middle situation from the last slide where we kind of bottomed out in the arteries, right? We had not enough fluid floating around in the arteries, and that could be dangerous. So what we can do to fix that and keep this up here, right? Keep these full, is, oh boy, hurry up, quick, make some changes in some of these other arterioles to some other organs, make those adjustments, and then we can maintain that volume and therefore that pressure in the big arteries, and then nobody really gets compromised, right? So what have they done? They just gave us an example. Aha, they really, really narrowed some of these. It looks like they kept this last one the same, but they really narrowed these to let hardly any blood go to these particular organs, and we kind of balance, and a little bit more goes there, we kind of balance everything out. Make sense? All right, so by balancing out stuff at various organs, we can maintain this, and that's safer for the whole body, right? So it's a little bit, okay, just hopefully temporarily we're gonna a little bit, cut off a little bit of supply, not totally, right? But we're going to cut back some other organs so that overall the body's going to stay safe. Make sense? All right. And we do that by changing diameters in the arterioles. Good? So we also remember that changing diameters in arterioles or any tube will change resistance, right? To flow of blood, right? We remember that from the first, it was like one of the first slides of this whole entire chapter, just talking about flow through tubes. Good? So, changing diameter, changing resistance, that changes the flow. That word resistance, right? That was part of this new term that we're learning about today, right? That total peripheral resistance. You see it? So this is what we're talking about, right? Resistance is going back to our original idea of changing diameter, right? So if the term is total peripheral resistance, now we're talking about peripheral is kind of like all over the body, right? But maybe not at its core. And in the cardiovascular system, the core is like heart and aorta and the big branches of the aorta, right? So a little bit further out, probably arterioles, right? And total is looking at the whole system kind of at once, right? Not just like, oh, out of the hand or something, right? The whole thing. Good? Total peripheral resistance. So this is what we're talking about. Okay. So this scary slide, I know it looks scary when you first look at it because it's a giant flow chart and there's so many things, right? So many bubbles and arrows and words and stuff. But if you just take a deep breath and actually look at it, it is actually 3 flow charts that we already know, at least 2.5, I would say. 2.5 flow charts that we already know, and we're putting them together. And we're just going to add a little bit off in the corner there. So let's see what we already know, because then you don't have to panic, right? Let's start over here. You see this part? On this left side, kind of upper left-hand corner, this is all stuff that we talked about the other day, right? On the venous side of the circulation, remember we could control that using sympathetic nerves to that little bit of smooth muscle in the walls of the veins, right? And then we can influence venous pressure, venous return, atrial pressure, and that preload. Remember that? That was just from Tuesday. And then, of course, preload is going to influence stroke volume, and, of course, stroke volume is going to influence cardiac output. You totally know that. Part of that same flow chart was changing blood volume. Same, right? We go through the same series of steps. Skeletal muscle pump, go through the steps. Inspiration, remember breathing in? And we change the pressures in the thorax and the abdomen to get blood to return, right? So we had that, and boom. We totally know that, right? From Tuesday. At least you guys, I know you're going to know it by Tuesday. This coming Tuesday, right? You'll have that totally memorized. So that flow chart is just like that. It's just right there. Good? So it's not new. Let's look at this section over here. Looks like this section is talking about sympathetic and parasympathetic, right? Stuff. So we've got sympathetic nerves to the heart. So this goes back, I think was it Tuesday? I don't remember if it was Tuesday's conversation or last Thursday's conversation, but it was one of those conversations, right, where we saw this flow chart. We had sympathetic nerves to the heart, influencing heart rate at the SA node, right, and stroke volume in the ventricles. Good, and of course those two influencing cardiac output. We totally know that. We totally know epinephrine doing the same thing, and we totally know parasympathetic complementing that, right? Helping sympathetic to do that stuff. So we totally know that. We know this whole half of the slide already. What are you talking about this? Great. So we've got that. And then over here, we remember this part, right? This was definitely Tuesday's conversation, and this was what we just sort of reviewed a little bit. How do we influence the smooth muscle in the arterioles, right? And we had our intrinsic controls. And remember, don't worry about the ones in parentheses. We're just going to focus on the big ones that we talked about, not in parentheses. And then we had our extrinsic controls that we just reviewed. Again, don't worry about the ones in parentheses. Just focus on the big ones. Let's see. And also angiotensin 2 and vasopressin we're going to talk about in the renal chapter. Good. So we know that they're there. We'll talk about the details for those two. But all right, we know this stuff, all influencing smooth muscle and arterioles, and that radius we just talked about is going to influence that total peripheral resistance. Good? This new thing that we're discussing now. So far, so good. All right, so we know all this stuff, right? Now we know all this stuff. Here we've got just a tiny little new thing off to the side here, hematocrit. But we mentioned hematocrit. That was like one of the, I think it was the first slide. The very first slide of this whole entire chapter, right, was hematocrit. What was our definition of hematocrit? What does that mean again? Erythrocytes, right? Okay, good. So it's basically like how many erythrocytes, not how many, but percentage, right, of erythrocytes. Good? All right. So percentage of erythrocytes, we'll talk more about this next week when we talk about blood, but we know enough already, right, that we can say, we know what that is. And that percentage is going to influence blood viscosity, which is basically the thickness, right, of the blood, thickness or thinness, right, of the blood. So that is also going to influence, it turns out, this total peripheral resistance, right, how thick or thin the blood is. All right, so the new thing also that we're talking about today is cardiac output times total peripheral resistance. Those are all both factoring into this mean arterial pressure, right? That number that's somewhere between systolic and diastolic pressures, that's the driving force for pushing fluid into the tissues. There it is. And here's this is our new mathematical equation, right? Mean arterial pressure, cardiac output times total peripheral resistance. Good? So this slide is like the master slide, right, for this whole entire section of blood vessels and pressure. Good? This slide. But keep in mind, all it is 3 previous slides put together, plus our little bit of additional information from today. Good? So it's not too bad, I don't think. Let's see. You want to know that one, obviously. Right? Okay, good. So, this table of numbers you also definitely want to know. We actually already know. I think somewhere along the line we have mentioned each one of these numbers or seen all of these numbers, right? So it's just a summary, putting them all together in one place. So you definitely want to know these, right? But we know cardiac output. We know that. We know systolic over diastolic pressures. We know that. We did that in lab. Here's that mean arterial pressure. If this is our blood pressure, this would be the mean. Of course, all these things are going to vary, right, from person to person and even within one person from situation to situation. So these are all just average numbers, but let's know what's the average, right? That's good. And then here on the pulmonary side, all the corresponding areas. All right, so that's pretty good. Let's see what else. So let's take a look at what happens to blood pressure, right, arterial blood pressure, in an abnormal situation to hopefully understand like normal, right? So even though a lot of times I say, oh, the abnormal situation I'm not going to test you on, it's just to help you understand normal. This one I'd like you guys to know because I think this is a really nice flow chart and it actually builds into another flow chart that's a little bit fuller. So I'd like you to know this one for the exam on Tuesday so that you can really understand the big flow chart that's coming. Good? You'll see it when we get here. Well, let's go through this one first. So our abnormal situation that we're going to look at is hemorrhage or blood loss, meaning like a severe blood loss. For whatever reason, it doesn't matter, right? We have severe blood loss. So, of course, if we lose a lot of blood, we lose blood volume, right? And that's overall in the body. If we lose blood volume, we're going to decrease the pressure on the venous side. We know that, right? If we do that, we're going to decrease the return. We know that, right? If we do that, oh man, we're going to decrease atrial pressure. We're dropping from 0. We start at 0, right? Remember that? Atrial pressure, 0. We're going to drop from that. That's bad. Okay, so you got that? If we're going to decrease atrial pressure, we're going to decrease preload, right? Decrease preload, decrease stroke volume. This is all stuff that we know, right? We just go through it with this specific situation in our head of we're decreasing. So decrease stroke volume, decrease cardiac output, and now here's our new thing from today. If we decrease cardiac output, right, we decrease this arterial pressure, right, mean arterial pressure. Good? All right, so that should be very sensible. Most of it we already know. Good? We're just picking a specific situation. So, to monitor such situations, whether it's extreme, like hemorrhage, or whether it's just a transient, relatively minor change, right, in the whole situation, we have built in to our system ways of sensing these changes and sort of monitoring and making decisions about these changes, and then sending out instructions like, okay, how are we going to fix the situation, right? How can we try to repair, right, make up for all these changes that are happening? Good? So, a little bit of anatomy review, but now we're adding a whole bunch onto the anatomy that we know. So obviously heart, aorta, and remember we've got our branches off of the aortic arch. And let's focus in on this common carotid, right, coming up the side of the neck, right? And they're just showing the left side. Of course, we would have the right side as well. But they're just showing us this side. That's fine. And let's remember that common carotid is going to branch, right, into external and internal carotids. Good? So right before the branching happens, we've got this little area where the wall of that artery is a little bit stretched out, and it's a little bit thinner than kind of everywhere else, right? Kind of leading into it. Kind of thins out a little bit, and we'll call it, first of all, give it a name, carotid sinus baroreceptor. Baroreceptor. So carotid, because we're in the carotids. Sinus, because we're a little bit sort of creating maybe like a cavern, right? Kind of a shape. So that would be kind of a definition of the sinus, like a space. And baroreceptor. Oh my goodness, we have to remember back to like neuro stuff, right? Ugh. Like receptors in neurons, that sense, right? And remember our sensory receptors? Oh, and we had all of our special receptors, things for like touch and pressure and pain and temperature and light, and sound, right? All the things, taste, everything. Oh my goodness. So now we're going to add to that, and we'll have some receptors that are sensitive to pressure, this kind of pressure from blood flow, right, that we're talking about. So we'll use this prefix baro to refer to pressure. So baroreceptor is a receptor specifically built to sense changes in pressure. Okay, this pressure that comes from blood flow. All right. So here's a nice overlap between, we've got cardiovascular system and nervous system, because these receptors are, just like the other sensory receptors, neurons. Good? So we've got overlap here. Good. So we have another set of very similar receptors, right? So they're going to sense the same thing. We'll call them baroreceptors, but we'll just put them in one additional location right in that aortic arch. So we've got two locations for baroreceptors, in the carotid sinus and in the aortic arch. They're built into that wall, right? The ends of the receptors are embedded in that wall. So that when that wall stretches and relaxes, right? Stretches and relaxes, and that's going to be constantly happening, right, with each heartbeat, right? And the flow through. Those receptors will constantly be able to monitor, right, what is happening as that blood flows. And it's kind of nice to put these receptors like pretty close in to the heart so that we can sense what's happening like right up front. Good? Instead of maybe later down at the knee or something like, well, a whole bunch of stuff happened between the heart and the knee. How are we going to control that, right? If all this other stuff happened. But here, close into the heart, oh, we could like catch something right away, right? If we have suddenly decreased preload and stroke volume, like that happened right away in cardiac output, that happened within a heartbeat, oh, we can know that. Good? Right away. So we'll take that information and we'll send it to very old friend, medulla oblongata, right? Very old friend from like anatomy. Good? We'll have a center there, medullary cardiovascular center. So located in that medulla oblongata, we'll have special clusters, right, that are responsible for taking in that information. And maybe figuring out right there, are we good? Are we too high or are we too low? Right? And then we can immediately send some information back, right? Send some information back to the heart if we need to, right? And to the arterioles if we need to, right? If we need to make adjustments in heart rate, in contractility, or in diameters, right, of arterioles. Make sense? So if that's what we're influencing, heart rate, contractility, and arterial diameters, what nerves are we using to send the information from the center? What part of the nervous system? Vagus, good, which is part of, let's see, let's work from vagus because that's correct. So parasympathetic, right? So vagus is cranial nerve number 10. Woo! Now you can pause. That's awesome. So cranial nerve number 10, vagus nerve, part of parasympathetic division. That's going to have influence. We know that already, right? Can go to the heart, SA node, AV node, influence that heart rate. What's it going to do? Take it down, right? Okay, so that's good. We totally know that. And then what would be the other side of that? So instead of parasympathetic, sympathetic, of course, right? And we know everything about sympathetic. Our sympathetic nerves, are we going to have any cranial nerves? No. Good. Ooh, that's boom. That's so good. So we have no cranial nerves involved with sympathetic outflow, right? But we could use perhaps some thoracic, right? Sympathetic nerves, because sympathetic nerves come from thoracic area and lumbar area. So let's tap the thoracic ones because we're up here, right? To influence the heart. Good? All right. So, but we can also send out sympathetic influence to any and all arterioles, right? That's our other thing that we can use, right? So we can influence the heart. We can influence arterioles, sympathetic, right? Remember that? Can we influence arterial diameter using parasympathetic? No, remember we didn't have any muscarinic receptors, right? On smooth muscle of arterioles. Okay, so we're getting it, right? It's all going to be like, this is all like preparing for Tuesday's exam. Super good. All right. Awesome. Let's see. So, let's see, having said all of that stuff, all right, so we're now sending out our messages, right, to heart and to arterioles using sympathetic and perhaps parasympathetic, right, if we're just going to deal with the heart, parasympathetic also. We're sending out all that information back, and we can influence back, right, and we can influence, like we know, heart rate, stroke volume, that influences cardiac output, and total peripheral resistance. Those two things together, cardiac output and total peripheral resistance, are going to influence that blood pressure, right? That mean arterial pressure, which is that number between systolic and diastolic. You see how if that's what we're aiming for, right, to influence, by the time we cycle around, right, maybe a minute later, right, we can come back and, maybe less than a minute actually for us, right, kind of young, healthy, nothing underneath going on. Oh wow, we make all the adjustments. Boom, it's like instantaneous. Make all the adjustments, and now the baroreceptors are still monitoring with every heartbeat, right? Monitoring where is that pressure, right? And if we made all the correct adjustments, you see how we're good, right? By just tweaking a little bit of heart rate, tweak a little bit of peripheral resistance somewhere, right? Get it? Is it starting to make sense? Maybe let the heart beat a little stronger, a little not so strong, right? We make little tweaks. We're not even aware, right? Little tweaks. Good? All right, and we maintain our blood pressure. Good? At a particular level that these baroreceptors are set to sort of like, right? Right? They're comfortable at a certain blood pressure. And we've been looking at that 120/80, right, as, kind of average. That's good, right? Normal or average. Good? All right. So we could be, as long as we're within that range, right, of 120/80, we could go a little bit above, a little bit below, something like that. For each individual will be a little bit different, and within that individual will be, different at different times. But as long as we're, pretty good in there, baroreceptors will be pretty happy, right? It's when you kind of go whoops or whoops, right? Then they're really going to kick in. They're going to be kicking in a little bit. We're always going to have, just like we said before, for blood vessels where we always have a little bit of sympathetic tone going on all the time. When we go up from there, we go down from there. Same thing for baroreceptors and the sympathetic and parasympathetic outflow resulting from their information, right? We're always going to have, based on the baroreceptor information coming in, we'll always have some sympathetic outflow and some parasympathetic outflow to maintain that normal range, right? But we can always adjust, right? We can always kind of adjust any of our options that we keep saying over and over again: cardiac output, stroke volume, total peripheral resistance, to oops if we go a little too high, or oops if we go a little too low, or a lot, right? Whatever. So, okay, so we have all of our tools. I think we have all of our tools. Having said all of that stuff, right? And you can read through, like, these are specific examples of, like, what happens if this happens or what happens if that happens. But here at the bottom, I wrote that this is considered to be a reflex arc. And we've seen reflex arcs before, right? We tested those when we were looking at tendon reflexes, right? So this particular reflex arc, see how it's, right? It's like a loop, right? We take in the information, we only go to medulla, and then we kind of send instructions out, right? We don't have to send it to cortex and like think about it and all of that. So in that sense, it's a reflex. And this reflex is specifically built to be a short-term thing. So, kind of a short-term change in blood pressure is sensed. We take that in, we make our decision. We don't make a decision, but the medullary center makes its decision, sends out its instructions, and that all just happens, and it happens quickly. And the intention is, we really only need to do this for a short while, right? Maybe while you're exercising, or maybe while you're sick, or maybe while you're nervous for an exam, right? Or maybe while you're threatened in some physical situation, right? These kind of relatively short-term situations. The intention of this reflex arc is not to make all these changes over a week, right? Like, you don't want to be in the same situation for a long time, right? A week, 2 weeks, a month, right? Oh my goodness, it's a little bit too much for this reflex arc to like maintain, to keep up with like, oh come on, what with the high thing, the high blood pressure, or what with the low, right? So if you keep yourself, for whatever reason, in this situation of too high or too low, this system will get kind of sick of it, right? We'll say, what happened to that other situation? you know what? We're so sick that we're going to reset ourselves. We're going to say, all right, you do this to us, we're going to say this is normal, right? We'll show you. So this system can totally reset itself if you stay in a situation and what's abnormal for you, right? If you stay in that abnormal situation long enough, they're going to say, fine, we'll go with you. We'll reset so that this is our new normal. And if that's high, do you see bad? If you reset to now your new normal is 160 over 90 or 180 over 90, that's not a good pressure, right? Suddenly we're starting to creep up into like hypertension as a disease process, right? Or let's say even worse, let's say you're now, then let's say the body gets used to that, and then you just keep going with whatever is your lifestyle, right, that encourages that, and you creep up to now we're at 210 over 100. Come on, right? This system, this little reflex arc is going to say, I'm sick of maintaining this, right? And you keep going up to here. I'm just going to reset, make my life easier, right? You're reset to this new normal. Good. And now your body's starting to get used to this new normal.
So that's only if the blood pressure is like too high or too low after a days.
Right. And usually it's more than a couple of days. You can. The body's pretty resourceful and resilient. So a few days isn't gonna mess this up. But definitely once you get out to like over a week or two, we're gonna start getting kind of like, can you get it all together, right? So you can always reset. Like let's say our example that I've been kind of going with is like resetting to a higher blood pressure because that's a huge, very common problem, right, in this country. You can always reset that back down, right? I think I did put in here. No, not quite. I think it's somewhere in the slides, but we'll talk about it more when we do get to renal system and we start talking about these other two hormones that we're a little bit putting off until renal, angiotensin II and vasopressin. Those hormones deal more with volume, right? Blood volume, which we know blood volume factors in to this whole thing. But it's that part of it, we won't get into the details today, but it's that part of it that is the basis of a lot of the hypertensive medications, which are diuretics, right? And getting rid of extra volume. But we know, we'll talk about it more when we get there, but we know that fits right in, right? Adjusting blood volume. If you take away blood volume, just go through the whole, our sequence, right? Decrease blood volume, decrease venous return, eventually decrease stroke volume, decrease cardiac output, right? And we can get at that blood pressure from that direction. That's a long-term thing. That's like, you messed this up, right? This was our short-term thing, and then you end up at the doctor and they're like, taking your blood pressure, whoa, what happened to you, right? So, and then look at the heart, look at everything, and a lot of times the patients end up on diuretics. But we'll talk about that when we get to renal, right? We'll set that aside. Good? But that's the basis of PART, right? That section of medications for high blood pressure. Good? But having said that, you can definitely get at high blood pressure in other ways. There are heart medications, and then there's also changing your lifestyle, right? And that's the whole basis behind relaxing, because then your sympathetic division isn't going nuts all the time, right? That whole section of that whole approach, right, to dealing with high blood pressure is not pretend or not silly, right? It's real, because we know sympathetic division is real. Sympathetic division has huge influence, obviously, right? Huge influence over this whole entire thing. So if you can get at your sympathetic division, right, and like, you can get at this, right? It takes work, but you can get at it, and you can reset, just the way you had reset. Make sense? All right, let's see. I don't know, what else? Oh, so anyway, this is just in flowchart form talking about a specific example from the previous diagram, right? So this is the example of increasing that blood pressure, right? Baroreceptors sense that, they increase their firing, right? And then we go to cardiovascular center and medulla oblongata, and then that center sends out the adjustments, right? Using sympathetic and parasympathetic divisions. Good? So this is just all the stuff that we said. But you can just see it in a flowchart. So here's that flowchart I was talking about that's like the big flowchart. Talking about hemorrhage. We talked about hemorrhage, right? And we had kind of a straightforward flowchart that had a lot of stuff that we know. So now we start off with hemorrhage again, and let's add, oh my goodness, now let's add all this other stuff that we know, including stuff that we know about baroreceptors. Good? And put everything in all the correct boxes, right, in the flowchart. So, okay, hemorrhage, we lose a lot of blood. Da-da-da-da-da. Reduce venous pressure, reduce venous return, reduce preload, right? All of that stuff. Reduce arterial pressure was our result of all of that. And baroreceptors sense that reduced pressure, right? Reduce their firing, and now they are going to send out all of this appropriate signaling, right? Using sympathetic and parasympathetic. We get at heart rate, right? Increase heart rate. Of course, that is going to increase cardiac output. We increase contractility. There's our stroke volume, right? Increase cardiac output. Let's see, there's also stroke volume, and here, increase total peripheral resistance, right? All using sympathetic and parasympathetic, all these things, right? Total peripheral resistance, there's our cardiac output, there's our total peripheral resistance. We've raised both of them, right? Because those baroreceptors sensed the decrease, right, in the pressure from the loss of blood. And we bring our arterial pressure, our mean arterial pressure up. Good? As a result of that huge drop. Make sense? So here in this flow chart, we're pulling together everything that we know and putting it in this particular abnormal situation. So that's why I do want you guys to know this flow chart. Even though it's a very specific example of an abnormal situation, I want you to memorize this one for Tuesday, because it's a great example of how does this work, right? And we draw upon everything that we know from this chapter, and we apply it, right, to this abnormal situation. Good? All right, so we're going to know this one for the exam on Tuesday, and for the final, I should mention. Because we're at the halfway mark, right? So we should say final exam. Good. So this is beautiful. Beautiful one. All right. Let's see. All right. This one is a little bit looking at the thing that I mentioned that we're going to talk about in renal, where as a long-term type of therapy, you can get at blood volume to control blood pressure. So for the exam on Tuesday, don't worry about this one, because we're adding in to our situation the kidneys over here and kidneys over here, and we have not talked about renal yet. We still have to get through respiratory, and then we'll hit renal, so we're a couple weeks away from that, and I don't want to go there, right? You guys have plenty on your plate, but we should at least know that's going to factor in. Right? Blood volume, obviously, is going to factor in, and kidneys are all about blood volume, right? So we should at least acknowledge at this point, yeah, that exists as an option, right? But we'll talk about how do we work the option in the renal chapter. Good? So you don't have to memorize this slide yet, right? For the exam Tuesday. However, for something like the final, right? Final exam is so much about where do all these individual chapters overlap, right? And this is where cardiovascular and renal overlap. Good? So this will be huge on the final. Good? All right. So, but not for Tuesday. We just know it exists. So, we've got some other influences on that systemic pressure. So let's go through the list. Things that can increase blood pressure. Let's see. I guess we'll just go through the list. I was seeing like, oh, are there any that we know? Well, we know like emotional stress, anger, anxiety. That's using sympathetic, right? So we do know that one. Here's something that we can say based on what we know, pain from the skin, right? So we've got pain receptors in the skin. They will register in the brain and trigger sympathetic outflow. So that's kind of how that one works. Decreasing the flow to the brain, we get the whole reaction, right? And that's coming from the baroreceptors are right there, right? Aortic arch and then carotid sinus, especially carotid sinus. Duh, that's going up to the brain, right? That's the reason that they're there, right? Aortic arch, sure, that would be good enough coming off of the heart, right? But let's for sure have like a second set. It's not a backup plan, it's a plan, right? But let's have our second set before we get to that brain, for sure, in case aortic baroreceptors like missed something, which they shouldn't have, but just in case, let's have an extra set of receptors telling us on our way to the brain, are we good? Are we getting enough blood flow to the brain, right? So that's what these are. So if we decrease the blood flow, we're definitely getting that blood pressure up, right? Because otherwise we're going to faint. Good? And that's actually what, going back to the lab on Tuesday, remember I had you guys lie down and kind of settle into that position and then stand up very suddenly and try to get that blood pressure immediately upon standing. There's a thing, and I think there's a slide coming up for it, but we can talk about it now. There's a mechanism or thing that happens when you do that. So you're lying down, the body gets used to that, and then you either sit up suddenly or you stand up suddenly. And you know, sometimes, probably for most of us, being young and healthy and like nothing underlying going on as far as I know, probably for most of us, we don't even realize it because the body kicks in so quickly. But what happens is that when you come from here to here or all the way up to standing, there you have a moment of pooling of the blood, right? Sort of down there.
Sometimes, like, if you stand up too fast and you get lightheaded.
Exactly, and that's what's happening. So sometimes it does happen, even young and healthy and all of that stuff. It's just, it's not as often as, let's say, an older population, like a lot of you guys will probably end up taking care of at some point, older populations, where things have been compromised, right, in the entire system, and so their response, right, to that temporary pooling of the blood sort of down in the lower part of the body, we don't get all of everything that we know, right, all of our tools that we have that we've been talking about now for a week. We don't get all of our tools to kick in immediately and like, aha, get that flow back, right, and up to the brain, and we're good, right, and the blood pressure is good, and the baroreceptors are happy, and right, we've got flow to the brain, and we don't get dizzy. But sometimes, we've all felt it at some point, right, where you do stand up too fast, and you're right, you have that moment of like, oh, just kind of, woo, sort of white out there, right, and have a little bit of dizziness, and you kind of have to, I'm fine, right? Woo, maybe sit down and just take a breath or something, right? And then you're good. Everything adjusts. So that came from the blood. If you had that sudden like postural change, whoops, all kind of pooling down in the lower extremities, and just for that moment, you didn't quite have enough, right? Flowing to the brain. and you have that moment, right? That's just a reflection of not enough flow to the brain. Of course, right away, baroreceptors sensed that and started getting everything, right, kicking into gear. But what did I say you probably did at that point? You probably like, oh my, and maybe sat down and took a breath. Are those mechanisms that we have, right? What do we have? The sitting down bit, right? Maybe we can get at gravity, right? Not pulling down on that blood, right? That column. Actually, let's go to this picture. Oh yeah, it's the next one. This picture is emphasizing when you're standing. See how everything, all these blood vessels on the venous side, they're like columns, and gravity will pull on those columns when you're upright. Good? So, oh my goodness, sit down, you take away some of that gravity, right? Some of that effect from gravity. Whew, so that's one thing. And what else did I say? Oh, you take a breath. That's one of our mechanisms. That's one of our tools, right? Inspiration. Oh, so that works, right? Whew, I'm dizzy. That'll do something, right? We totally know that. So it makes sense. It's not silly. Good? It's a real thing. It's a real thing. So, let's see. So we've all felt that, right? At some point, hopefully, most of us don't feel that terribly often, right? But in older populations, yeah, you'll see that. You'll come across that more often. So always keep in mind when you're helping an older person, let's say out of a hospital bed, something like that, they might need some time, right? To kind of, sit up. Don't like, all at once, a little bit. Let their body adjust, right? Baroreceptors, everything that we know. Adjust and adjust, right? A little bit. And then swing their legs over, adjust. Then help them stand up. Good? But now you know why, right? Because their bodies take a little more time to get all the tools that we have sort of going, right? Kicking in. All right. Good? All right. So let's see. So anyway, here's, we skipped ahead. Here's our picture of gravity's effect on that venous side. And all those words that you can read through, that is just talking you through all the stuff that we know, right? Step by step by step. So you guys can totally, you can do that. But let's go back to that list really quickly. Other stuff that can influence blood pressure. Let's see, what else do we have? We're going to look at concentrations of oxygen and carbon dioxide in the arteries. We will look at that in respiratory system and in renal system. So we'll acknowledge that, and we're going to talk all about those details in those two chapters. Good, because that's going to play into acids and bases. So this is why respiratory is the hardest chapter, right? Just kind of looking ahead into next week, because respiratory has a lot of physics and it has chemistry, specifically acids and bases in there. So that's why. But respiratory is very cool. So if you can wrap your head around it, you're really good at it. Really good. All right. But anyway, we're going to talk about that stuff in respiratory and renal. Let's see. And then we have this abnormal situation. This is more of an FYI thing, but something called Cushing's phenomenon, and that's a rapid increase in pressure inside the cranium. Usually this happened because of some injury, and blood pressure shoots up because of that. But that's kind of an abnormal situation. So that's just FYI. Stuff that decreases blood pressure. So we have a little drop when we're sleeping. We know, calm, right? Emotional, right? Playing into all that sympathetic, right? Calming down, not so much sympathetic, right? More parasympathetic. So we know that. Pain from viscera. So when we think of surgery, cutting into the skin, just the skin, raises blood pressure temporarily. Continuing cutting into the viscera will bottom out the pressure. So this is where the anesthesiologist becomes like important person monitoring that drop in blood pressure that happens when you cut beyond the skin and into the viscera to be sure that you don't stay bottomed out, right, while you're having that surgery. Also in joints. So anyway, and then we have, here's something, vasovagal. That should sound familiar, the parts of it. Vaso for vessels, vagal for our friend, right, vagus nerve. Good? So vasovagal syncope. Syncope is our fancy word for fainting. So we can, because of too much vagal stimulation, go to ground, right? So that's okay. Vagus nerve, we know parasympathetic, usually some sort of strong emotional thing happened, like you saw something that was just too much, right? And vagus nerve just suddenly had this flood, right, on that parasympathetic side, and you just, oh man, right? So we hear about that all the time, right? I don't know if anybody's ever fainted. Has anybody ever fainted?
Only after blood being drawn.
Yeah, a lot of people faint because of blood draw, but that has to do with this, actually. Yeah, I think it was in the OR. Bad. But that was like a medication thing. Huh?
I fainted while at work at a hospital because I was in a procedure room and somebody was getting like a pacemaker put in their body.
Yeah, and that's a lot of this. Like if it's something that's just like, a lot of times it's this visual thing, or sometimes it's a smell thing, you know, where it's just like, that was too much for you at that moment, like emotionally, and you just, parasympathetic system just goes crazy and releases. What's parasympathetic system going to release? Let's do a little review. Parasympathetic, acetylcholine, right? Okay, and you just bottom out because of all the tools that we have, right? Especially on that heart. Right? We go through our list, and blood pressure, right? Just doesn't get to the brain, and you just faint. So what is really fainting? Fainting is embarrassing, right? I mean, I fainted too. I was so embarrassed when I woke up, right? So embarrassed. But, okay, besides that, what really is fainting besides embarrassing? It's a protective mechanism. If your blood pressure, meaning your blood flow to your brain, just like bottomed out and suddenly you're not getting flow to the brain, and that's why you fainted, you just like blacked out. What is it? What happens when you faint? I just said it. You go to ground, right? Using our tools, thinking about our tools. What is going to ground?
Makes your blood go to your head.
Horizontal, right? So that, like, physically, right? The blood is gonna go, right? To your brain, right? While everything else kicks in desperately, right? Baroreceptors going insane, right? Fixing everything. But at least you're horizontal. So while your body is adjusting like crazy, we're getting flow to the brain, right? For that whatever, however long it takes, right? A few seconds or a minute or something like that, right? You're still getting flow to the brain because you're horizontal, right? So the fainting is a protective mechanism for the body.
I had heard, and that was what I was curious if you like heard it too, but I think it may be kind of like, it's not true, but that when people faint because they see blood, it's like a primal instinct to like when you like when you like Neanderthals are like fighting and they see blood or something, then it's like a dangerous situation. So they're like, it's like a way to kind of keep themselves like to faint and play dead kind of, so that like you don't get involved in like a bloody like dangerous situation. I heard that. So
yeah, exactly. And maybe that's not like directly having to do with, you know, physiology. I mean, of course it is the mechanisms of physiology, but that's more like looking in that big sort of evolutionary picture. And it is, in that sense, also protective. Like what we were just talking about was like physiologically protective to that brain at that moment. But in the big picture, let's say we look at a group of individuals and who faints, right? And wow, maybe those people who fainted didn't end up getting killed. Like you're saying, right? They play dead, that's an animal. We're animals, right? So in the big, right, evolutionary picture, of course, it's cool. All right, super awesome. Let's see. So we looked at this picture already. The next few slides are really, and I put up in the corner FYI, I'm not going to test you on all of this information, but I felt a little bit bad taking them out completely because I thought, well, some people, I usually end up in physiology class with a good handful of people interested in kinesiology, like exercise stuff. So I kind of kept all this stuff in because some of these slides speak to changes that happen in the body, like when we're exercising. But you don't have to know all this stuff for our exam on Tuesday or for the final. This is just stuff if you want to look at it and kind of think through things yourself, like what would happen in different situations. Like here, what would happen to the flow to this particular list of organs when we exercise, right? And you can look at the changes, especially flow to like skeletal muscles, right? You can look at that. This is looking at pressure. No, what is this? There's cardiac output. There's some flow and there's some pressure. So kind of looking at more numbers with exercise. This is more of like a flow chart version of what happens during exercise. And in the table form, right? So you guys can look through these, but I'm not going to test you on that. And oh, of course, a graph, right? A series of graphs. Graphs. But also with exercise. Let's see. So that brings us to, we'll take a break, but that brings us to the blood section. So before we take our break, just to be sure we know, the exam on Tuesday. Exam on Tuesday covers, let's see, this is slide 84. So it covers, let's see, the last slide is 78. The first slide where we started today was 67. Oh wait, but we have all the vessel stuff. So we started blood vessels. Capillaries. 37? Yeah, here we are. So starting at 37, this is for Tuesday, 37 through 78, right? Exam on Tuesday. Of course, don't forget all your stuff from 1 through 36, which was hard, right? Because factoring into all the blood pressure and the blood vessel and blood pressure stuff, of course, is our foundation, right? From the heart stuff, especially that cardiac output part, right? Stroke, cardiac output, stroke volume, heart rate, right? Like that's and sympathetic, parasympathetic, all that stuff, like factors in and overlaps with blood pressure and blood vessel stuff. So don't just blank out on that, right? All right, but the focus of the exam, 37 through 78, and then the exam on Thursday will pick up at, we'll pick up at 84. So let me just jot that down too for myself. Hang on, and then we'll take our little break.
Which side is 84?
Huh?
Which side is 84?
This is 84. This is 84. So we're going to pick up Tuesday. I don't know what day it is, whatever day it is. We're going to pick up 84. Huh?
The 28.
It's a 28. Oh my goodness. We'll pick up with 84 and then move on to blood. Good. And that exam will show up on Thursday. Good. Let's take our break. So let's come back at like 9:20. We'll take a longer break because I want to record